Okay, John and Cullen, let's spend a little time talking about post-op care. And one of the things that I like to discuss with post-op care is the dry eye nighttime issue thing that you hear about with LASIK. And I'll never forget when we were in the PROWL study, the patient reported outcomes with LASIK study, the study that the FDA sponsored, PROWL 1 being for military and PROWL 2 being 5 civilian centers. And we were one of those centers. And it was really looking at the dry eye issue with LASIK and the nighttime issue. And sometimes it's worth people just going and reading the study, because what was so interesting about it is that with quality patient selection and quality preparation for surgery, there were more dry eye symptoms pre-op LASIK than there were at 3 and 6 months post-op, and there were more nighttime issues pre-op than there were at 3 and 6 months post-op. And we all know that with a normal healing surgical procedure, there can be these things, but it sure was comforting to the world to get the prospective patient-reported outcomes with LASIK study. And so let's talk a little bit about that. We know that with LASIK, it even seems that dry eye patients can sometimes self-select because they had a hard time with contact lenses. And how do you handle that tear film aspect of this, John? And how do you diagnose and treat? And then maybe Cullen will get you some of your thoughts about what you do maybe in addition. John?
Yeah, absolutely. I think the biggest thing is to figure out the patients that have a dry eye beforehand and treat them aggressively before they have the procedure, because obviously if they have one before, they're going to have a dry eye after. And we do the normal dry eye testing and determine what type of dry eye they have and treat it appropriately. But if you don't address it beforehand, patients get very fixated that surgery caused it, and that's, I think, the main thing you want to avoid, in this group of patients.
Yeah, Cullen?
Yeah, the ocular surface obviously is so important for us to see well. And so we really want to get it into the best place that it can be for both before and after, because especially after, when we're comparing, hey, how's my vision after having this done? If there's anything that's going to interfere with it, like the eyes being dry, it's going to feel like the outcome wasn't where they were hoping it would be, where all of the planning and testing and laser treatment could have been 100% spot on, and a little bit of dry eye is causing them to feel like something didn't go correctly when everything went great. So really focusing on getting the tears into a good spot, whether that's through artificial tears or medicated drops like some of our dry eye regimen drops, or doing things like punctal plugs. There's a whole array of options that we have to get people into a good spot for the tear film.
Yeah, I'm thinking about it also like you guys, every step of the way. I even find myself, when I'm first starting that conversation with the patient, I feel like I can sometimes even see from a distance that their tear prism along their lower lid is just not what it should be, or maybe some subtle redness, or even the history of vision varying with blinks. And I know for sure I don't want to, operate on someone that has corneal staining. I know that's a stressed surface, and I want to get that cleared up before we would ever do surgery. And sometimes I find that patients want to minimize the tear film because there can be an extra investment in it also. And so I actually will tell them right where the air meets your tear film is the most powerful focusing element of the eye. when it comes to image quality, it's hard to imagine anything more important than your tear film, and that there's also almost 2,000 proteins in your tears. Your tears are anti-inflammatory, they're antibiotic, antiviral, antifungal. They carry nutrients. They're important for healing. I like to call it the blood of the cornea because I'll explain to patients there's not blood vessels in the majority of the cornea. So to get all these important healing factors, that tear film is so important. So both optically, it's so important for your image quality, and therapeutically, and very important studies that have shown an undertreated tear film, not only is there increased risk with surgery, but there can be a higher rate of regression, so a higher enhancement rate. And I always think about, in general, I love treating tears for 2 or 3 months pre-op because that tear film can go up. And a lot of people don't need that. Some people, we can be treating it almost in parallel, but that tear film is just so important. And I don't know about you guys, but I feel like a lot of the dryness we deal with after LASIK is underdiagnosed and undertreated pre-op dry eye. And so every now and then I'll just cancel someone and say it's just not time. Let's treat your tear film. What about, guys? Let's say you have that 5-diopter LASIK come in, and they're 20/20 day one. Excited about that, but they had some nighttime glare and halos that first night of after surgery, and they have a little anxiety. John, what do you tell them?
Yeah, so I think it's along the same line as the dry eye. I tell everybody before surgery that they will have some halo and glare at night after surgery. They will have some increased dryness, and that these things all subside with time. They're the part of the normal healing process. And as long as the patient understands that, they're fine with it. And if they don't have the dry eye after surgery, well, it's okay to be wrong, that they're not going to have it. But it's just like everything. If it's what they expect, then and they know it's normal, I think you're way ahead of the game.
And Cullen, anything to add?
Yeah, I always tell people whenever they are just immediately post LASIK that day one vision, it's going to look like looking through a foggy window or a steamy mirror. And so those things are totally normal, and it'll clear up over the next week. And so the day one vision, our main thing is just making sure that things look good, everything's in place, and providing some reassurance that the vision will continue to clear up.
How about you're seeing that patient, John, and that you see a little flap irregularity. They're seeing 20/20, but they feel like maybe the image quality could be a little bit better. Do you observe or do you do something about that?
Yeah, so in the old days we would observe these, and we just found that subtle irregularities in the flap can make a big difference in image quality. Even though they're seeing 20/15, they always will notice a difference between the two eyes. And so I think early intervention on flap irregularities is key. Lifting a flap at day one is much nicer than lifting a flap at year one. So.
Yeah. It's one of the reasons that I like doing flap checks also before they even leave the day of LASIK, just to make sure. Sometimes, we can take care of it right then and there. And Cullen, let's say you're doing that flap check and you see a little debris under the flap. What would you consider you should rinse, and what would you consider is okay to observe?
Yeah, for the most part, the mild amount of debris we see under the flap can be observed. Most of it is usually meibomian gland discharge, and so that will dissolve on its own. If I see something like a fiber from the sterile drape or something that just looks very abnormal, then obviously we would want to lift that and irrigate that out. And I also am a proponent of checking the flap before they leave that day. So I pull them up to the slit lamp immediately after the procedure and just take a quick look to make sure there's nothing obvious that's right there. Really easy for us to just go lay back down on the LASIK bed and lift right there and pull any major debris out should it be there, even though it's pretty rare for something like that to happen.
Yeah, wonderful. And John, you've seen a lot over the years. Let's say that it's day one and you're seeing some white blood cells. And so you're thinking DLK, diffuse lamellar keratitis. And how do you handle that?
Yeah, so DLK, pretty rare at this point, but steroids are always your friend. I would increase their steroids and watch them closely. Typically steroids will take care of DLK. There are some more aggressive forms that, if at day 2 or 3 things seem to be going south instead of getting better, have the patient come back in and irrigate the flap and just wash out whatever's causing the problem.
Yeah. Anything to add, Cullen?
I think that's the big thing. The focus is really to really hit the ocular surface hard with steroids to make sure that we're calming down any inflammation that's there. If it looks really severe right away or you're really worried, always we're happy to take a look to make sure everything looks great.
And I think that's absolute key. Both of you guys nailed it. And I think that the other thing I would like to just emphasize is the importance of closer follow-up, because if the steroids are helping a mild DLK turn the corner, wonderful. If not, even seeing them at day 2 post-op and making sure that they are not progressing, because really what we're trying to prevent in LASIK is an inflammatory episode that leads to what we call central toxic keratopathy, and so that's where you can start to get a cracked mud appearance in the flap, and it is rare, like John said, but that's what we're trying to prevent, because typically those get better with time, but it can be a 6-month to 12-month course. And so if you see interface cells that are beyond very mild, I think it's worth a phone call right then and there to together decide, is this something to just handle with topical steroids, or do they need an early lift and rinse? Because it's felt to be due to some residue or something from, whether it's an operating instrument or something that got under the flap from their tear film that is really creating an inflammatory reaction that's beyond normal. But great job, guys. And so let's say that we have a patient that did well postoperatively, and now we're seeing them at 3 months. They had 3 diopters of myopia. They feel like they've never seen better without glasses or contact lenses, but they want to see a little bit better. So you do a refraction, and they have a half diopter of myopia that is really bothering them. Let's even say it's minus 0.5, minus 0.25, axis 180. They're seeing the 20/20 line just not as crisp as they would like to. And you're preparing them for an enhancement. What extra would you tell them, Colin, about the enhancement that you think is important?
Well, I think when we talk about the enhancement, we talk about how we're going to have to be lifting that flap back up again. And then the risks that come along with that, which it's again uncommon, but you can get some of that epithelium that goes underneath the flap. And if you get some of that epithelium under the flap and it ends up being central, that epithelial ingrowth can really cause big changes in prescriptions over time. So I think that's the big thing that we worry about. The other thing that I talk to them about is that over those first 3 to 6 months, the vision can continue to fluctuate a little bit. And so I always want to have them come back for 2 or 3 times to make sure that the refraction is the same between those 3 visits, because otherwise I feel like we're just treating a moving target.
Right. Beautiful. And John, you've dealt with epithelium. When do you observe? When do you do something about it?
Yeah, so if it's in the periphery, I will observe. If it's moving centrally, if you see it migrating centrally, then definitely you want to intervene. I think the easiest way to watch it is increase of cylinder. So as the epithelium increases in thickness in the periphery, it will cause central cylinder. So if you see a patient that you notice the cylinders creeping up each time and they have some epi, you want to intervene.
And that's how I handle it too. And um, I think one of the most important things is just calm the patient, educate them that these are very normal cells that are supposed to stay on top of the flap. But they have a very high mitotic index, and I'll even explain cell division. You remember from high school biology, mitosis. And so these cells undergo their normal life cycle, and they're supposed to, do their job, then die and slough. And if they're under the flap, it's hard for them to slough. And if they continue growing, those epithelial cells that are dying can release hydrolytic enzymes that can melt the edge of the flap or melt the stroma. So it is something important. It does warrant extra follow-up. But I think like John and Cullen, both of you, I agree. If it's little and not progressing, observe. If it's progressing, then we probably need to lift and clean that out of there. And I am always trying to think of things that are causing it. I usually reason that it's related to nighttime dryness. And I'll tell patients, do you use a ceiling fan? And I'm I don't like ceiling fans for LASIK healing and drying out eyes because a lot of people have a little exposure at night. And so we'll treat their dry eye real aggressively to lessen the chance of it coming back. And John, I know we have this great portal with a lot of our post-op thoughts and tips. You want to mention something about that?
Yeah, absolutely. We have a portal. It's vancethompsonvision.com/OD that has all our pre and post-op recommendations and suggestions for all our procedures. So it's a good place to go for the information. And it's set up such that when you're seeing a patient, you should be able to access the post-op, 1 month exam section very easily. Just to kind of tells you what to look for and when you should potentially send that patient back.
I think that is a great resource, and I think this post-operative time is such an important time, and we love it when we get the phone calls, the text messages. I even love when we get them that, hey, Jamie had LASIK and I'm seeing her 1 week visit, and wow, she's happy. I even love getting those. So any questions or concerns, we're at your fingertips for those. Any closing remarks, Colin, John?
I think we touched on some really important points here. I think the important things are that we are looking out for those issues that could set us back, make sure that we are talking with the patients to make sure that we're both speaking the same language. And then, we're all walking through it together to make sure that everyone's being heard and we get through it together.
Thanks, Colin. John?
Yeah, absolutely. You know, we just always want to do what's best for the patient. We're in a day and age now where we have a lot of different technologies and options for them. And I think communication's the key between not only us and the patient, but us and the referring doctor, so that we're all on the same page and support the decisions that have been made. So we love the phone calls as well. We're happy to discuss, you know, individual patients at any time.
Well, I've really enjoyed doing this podcast with the both of you as we've covered preoperative and operative and post-op. And thank you so much. And thank you to all of you who are listening, and have a wonderful day. And